Welcome to Let's Talk Oral Health by Gum, your source for conversations on oral health and beyond. My name is Rachel Chau, and I'm here with my co-host, Martijn Verhulst.
Hello.
Hello, Martijn. Today, we are diving into the fascinating intersection of oral health and systemic diseases. And for that, we are very happy to welcome a household name in the world of periodontology and an expert in periodontal medicine. I'm talking about Professor Bruno Loos.
All right, yeah.
Hello, Bruno.
Hi, thank you for inviting me.
Thank you for being with us.
Yeah.
We are thrilled to have this conversation with you.
Yeah, thank you for inviting me and having me here and seeing the headquarters here in Switzerland.
I think you had a small glimpse of the vibe in the building with the Japanese paintings, the Japanese VIP room. So you understood that Sunstar has Japanese origin, and with that, it has actually an intrinsic, holistic approach to oral health. So you are a Professor Emeritus at ACTA in the Netherlands.
Yes.
So ACTA being the Academy of Dentistry over there. Tell us a bit more about your background.
So, okay, thank you. I'm Professor Emeritus in Periodontology. I'm from ACTA, and ACTA is actually the Academic Center of Dentistry in Amsterdam. And I've been working there for 32 years in the Department of Periodontology. And I have been engaged, of course, in teaching and research and patient care in the department, and also teaching a lot for postgraduate students, becoming a periodontist. And with lots of pleasure, and still ongoing with current PhD students. Yeah.
And before your time in ACTA, you also spent some time in the US, if I'm not mistaken. Could you maybe share in a few sentences what you did?
That was a long time ago. I did my periodontal training in the US, and after my clinical training for 3.5 years, I went to the State University of New York in Buffalo University, and Department of Oral Biology. And there I did my PhD.
Right.
And I studied also oral biology.
And I understand that ACTA is actually what links you two together, because there is some sort of a special bond between the two of you. So, Martijn, maybe you can tell us a bit more about that.
Yeah, sure. I mean, it's true. Before I joined Sunstar, the company, I was doing my PhD research in ACTA, and that was under supervision of Bruno. So I always say I have actually two fathers, my biological father and my academic father, and Bruno is my academic father. Nice. So, for me, it's a very nice opportunity to also work together again after 10 years when I started my PhD research, and now we are back in the same environment. And I remember from my time in ACTA, there was always we used to have these weekly meetings, to discuss progress with the research, and it was always Bruno asking me, whether we were sitting alone or with colleagues, it was always, Martijn, can you maybe explain again, what are you doing with your research? Can you maybe repeat, what are you trying to investigate? What are you trying to show? And every week it was the same. And to me, at times, that was a bit annoying, because you had to repeat yourself every time. And I was thinking, doesn't he even get what I'm actually doing? But then later I found out there was, of course, a way to keep you sharp and keep the focus on what you're doing. And you need to be able to always explain what you're doing. And that is actually very nice, because that's exactly what we're going to do today. Because this time I'm not the one who's being asked, can you tell us what you do? But we are going to ask Bruno.
Yeah, but maybe we can start with you. What were you doing?
That's a good point. Yes, exactly. So my research was focusing on as Bruno's research always does, on the oral systemic link. And we were investigating whether we could implement an oral care protocol in diabetes care, so in primary diabetes care with family physicians, and see if we can bring the two disciplines of medical care and oral care closer together, work closer together, and then see what does it actually mean for the patient. And in the end, we found that when you actually do that, you can achieve improvement in quality of life of the patient, because that was the primary outcome of the research. Yeah. And we did several other projects related to the oral systemic link, but that was really the key focus of the research. Trying to bring the two disciplines of medical and dental care together, and instead of working in silos, try to work as one task force for the benefit of the patient. And that was actually what we showed. So, yeah.
And it was, I think, a very unique project because we really worked together with 22, I think,
24, yes.
24 practices, family doctor practices,
yeah.
and family physicians. It was very good, and it was an RCT,
yeah,
a randomized controlled trial. So it was nicely set up.
Yeah.
So, yeah,
it was a lot of work, but it was worth it.
Yeah.
So.
But it's like a reunion actually for you today. And the topic of your research is actually a nice entry point for our discussion because we are talking about the oral systemic link. And we know that the link between oral health and diabetes has been one of the most well-documented relationship, bi-directional relationship. And talking about all your experience at ACTA, your work, you have done a lot of work on this topic of diabetes, and you have published dozens of papers on that. So my first question to you, Bruno, would be, could you maybe unpack for us all the most important learnings after all these years of research on the topic?
No, but I think in terms of the relationship with diabetes, after all those years, the relationship between diabetes, particularly type 2, and periodontitis has never been refuted, has only been strengthened. So it is very clear, and today we even better understand why this relationship exists. It's the fact that when people having diabetes type 2, and particularly when it has not been completely diagnosed or it's in a pre-diabetic phase or poorly controlled, the patient is more susceptible for inflammatory conditions, infections everywhere in the body, and also blood vessels may be affected, and the whole immune system is affected. So obviously or logically, we can also realize that when people have inflamed gums, that will worsen because of the diabetes type 2. So, and that means worsen periodontal inflammation, and it will accelerate the progression of the disease. So that is to wrap up that we really understand, and it's not that difficult. The periodontitis in that respect is not different from another systemic disease or inflammatory process. It's negatively affected by poor diabetic control. So people with poor diabetic control will have more inflamed gums, will have progression of their periodontal disease, may have periodontal abscess formation, and unfortunately. So in recent years, we even think, and research has shown that many people that have been referred to our clinic for periodontal disease and periodontal treatment may have a state of prediabetes or even diabetes while they are unaware of it. So in our clinic, having these patients, it may be a sign that they have diabetes. So we even shift that in the periodontal clinic, you could theoretically identify new patients for the having diabetes. So I hope this is a very short summary, but the link is clearly present.
Yeah, as you said, it's really established.
It's very established, and actually you have to realize that the prevalence of people with diabetes among patients with periodontitis is at least double as the prevalence in the general population.
Yeah, we always talked about periodontitis being one of the complications of diabetes, right? If you have diabetes, because of the chronic inflammation, you see that you develop eye disease, kidney disease, neuropathy, so your nerves become damaged, and periodontitis fitted into that line of complications, and that was, I think, already introduced in the 90s. But I also remember when I was doing the research myself, and that was the moment in time where there was a lot of attention on the other way around of the association, because now we're talking about diabetes being a risk factor for gum disease and for periodontal inflammation. But the direction is not just in that direction. There's also another way around. Maybe you can elucidate a little bit on that direction also.
Yeah, I think we have to realize that any form of chronic inflammatory condition in the body can disturb the metabolic condition and balance in the body, and can disturb, you can say, the sugar levels and the levels of insulin, and can increase the insulin resistance that is found in diabetes. So having an untreated inflammatory condition, including periodontitis, may speed up or worsen the pre-diabetic phase into full-blown diabetes, or having people not having diabetes maybe speed up their movement towards having pre-diabetes.
Yeah.
So yes, indeed, periodontitis is not unique. I want to stress that it is something for other inflammatory diseases as well. But obviously, we are talking about oral diseases, and periodontitis is one of these that can worsen the metabolic condition and insulin resistance.
Yep.
So that is the two ways, and even I know of a Korean study, a big, large epidemiological study that has shown that people with periodontitis, you can see that they developed the diabetes faster than the control group without periodontitis.
Yeah, maybe of the Korean enhanced equivalent study. Yes.
Yeah.
Yeah. And I also remember when talking to the family physicians, sometimes they said, when I have a diabetes patient who's poorly controlled, and I'm doing everything I can, I'm doing as much as I can on diet, on physical activity, I'm even increasing the drugs, and you still struggle to get good glucose control. And then later they found out that there is a chronic inflammation in the mouth going on that sort of disturbs their treatment efficacy. And that, again, sort of emphasizes that you cannot ignore oral health when you are treating a patient systemically. Yeah. And I think that was quite a nice...
It's an example of where the dentist and the physician should work together. And the physician having his diabetic patient, that she should ask, have you been to a dentist lately? Have you been checked for gum disease, periodontitis, and vice versa? And a periodontist or a dentist who sees a patient with severe periodontitis should be aware that there might be underlying diabetes.
And there's, of course, the nice evidence that when you, correct me if I'm wrong, but it's also, I think, in the EFP guidelines, acknowledge that if you treat periodontitis in diabetic patients, it can result in an improvement in glucose control.
That's correct.
So taking away the inflammation can really bring down the blood glucose in a way that is clinically relevant. But
it's actually not specifically the blood glucose, it's the HbA1c. And that has been reduced, although the literature shows it's significantly reduced, but it's never reduced to the level, on average, to the level below the threshold of diabetes, unfortunately. But by the way, these studies have been very interesting, because the reduction in HbA1c due to periodontal treatment is about 0.5%. And it has been recently confirmed by the Cochrane Institute also. And they claim there's no further intervention studies needed. But this reduction in HbA1c is on top of their normal treatment,
right?
Because people are recruited to having periodontitis and diabetes. They have a diagnosis of diabetes. They have been treated by their physician. And then we do the periodontal treatment, and then you get another reduction. So it's a powerful therapy, periodontal treatment.
But if you say diabetes has an irrefutable link to periodontitis, it's not the only one. Another focus of yours during your research was also cardiovascular diseases, which is also very much linked to periodontal disease in general. Can you maybe also tell us about the evolution of the understanding of this link and where we are at now today?
It's about, you can say 40 years ago that the first time it was mentioned that there might be a link between oral health or oral diseases, periodontitis, and cardiovascular diseases. And that was shocking, very interesting, of course, and made people much more aware. And over the years, many studies, cross-sectional and longitudinal studies, have continuously proven that there is a association between oral health or oral diseases actually and cardiovascular diseases. So that is also like the diabetes link. It is a link between, and particularly the periodontitis and cardiovascular diseases, a link that should not anymore be doubted for. It is definitely existing. However, as we move through time and a more recent development is that on an epidemiological level, we realize that it is not the whole periodontitis population that might have an association with cardiovascular disease. Within the periodontitis patients, there are subgroups. And some are some clusters or silos or buckets, what Jim Beck calls them, of people that are much more have a much bigger association and link with cardiovascular disease among these patients with periodontitis. And other patients may have more links to other systemic diseases. So it is a challenge for the future to sort out which groups of periodontitis patients are have more the relationship with cardiovascular disease and diabetes versus a group that we have found in recent years in research. A group of periodontitis patients has much more a link and associations with respiratory diseases and rheumatoid arthritis and other types of immune diseases. Mm-hmm. So it's as we move forward in science, we see that where we had in the past pooled all the patients together and had average scores, we do find out that there's definitely individual differences, individual groups of people, rather than everybody the same. It's intuitively normal, but we didn't do it before. But now we can, with more advanced statistical techniques, we can cluster people and find these things out. By the way, there are also periodontitis patients not having a link between cardiovascular disease or the diabetes, luckily. Yeah. So that's another group of people. Yeah.
We're going into the underlying mechanistic discussion in a few minutes, I suppose. But besides these epidemiological studies, you also have quite some knowledge on more the fundamental research behind this association between periodontal disease and cardiovascular disease. For example, researchers finding oral bacteria in the atherosclerotic plaque. Could you maybe shed a little bit of light on that without going too much into detail on the underlying mechanisms, but some of these key findings that we did in the past decades on this association?
So indeed, if you look back at the last 20 years, we have been trying to explain mechanistically how periodontitis can be associated with cardiovascular disease. And that was actually a quest towards a causality of periodontitis into cardiovascular disease. And today, I think we really better understand that like periodontitis, cardiovascular disease is also multi-causal. There's multiple factors that work at the same time to eventually get to the true disease event. It's not one thing. So it's not only bacteria coming from the mouth, but it is one of the explanations why atherosclerosis is developing, that there are bacteria from the oral cavity in the circulation, and they might dislodge into atherosclerotic lesions. And even if they are dead, their components can stimulate the immune system, can stimulate inflammation in the vessels, in the blood vessels, coronary arteries, for example. And so that could worsen the atherosclerotic process. But the oral bacteria are not the only bacteria that have been found in. There are many types of bacteria found in atherosclerotic lesions. And mainly and mostly they're not alive, they are dead, but somehow packaged into large macrophages and foam cells and giant cells, but can still have their mechanistically their LPS, their lipopolysaccharide or their endotoxins that can stimulate the immune system and exacerbate inflammation in such lesions. So, but that is one mechanism, but there's also the issue of, say, autoimmunity, that because of the periodontitis, autoimmune cells develop, autoimmune antibodies develop. So there's various processes what can explain mechanistically how the immune system is affected by periodontitis and having a negative effect on the generation of atherosclerotic lesions and can worsen the situation. But let's be fair. To me, causality of periodontitis to cardiovascular will never be found, even though there's overlapping genes and the mechanisms we talked about, and the inflammatory mediators that from the oral cavity spill into the circulation. It all adds up, but not per se that periodontitis is a causal problem, because we didn't talk about cholesterol and exercise, obesity. So the two diseases, what they do is they share genetic components, they share lifestyle factors, negative, poor lifestyle factors, and other aspects that why they co-occur.
I think that's actually the next segment. We're going to talk about
the comorbidities, the fact that there are several diseases that can be can actually work together, unfortunately, like diabetes, cardiovascular disease, and obesity, which is a comorbidity, but also a disease by itself. And maybe you can also, you talked about the mechanistic link between periodontal diseases and cardiovascular diseases, but it would be nice if you could also do that for the link between obesity and oral health.
Yeah. And the role of obesity in the relationship between, all those chronic diseases. It looks like it's all interconnected.
Yeah. And the thing is that obesity, we can consider a disease, actually an inflammatory disease. In fact, an inflammatory disease of the lipid tissues in the body, and particularly inside the belly. So the cells are chronically inflamed. And when they are chronically inflamed, we call them, they are under stress, and they release many more pro-inflammatory cytokines. So you can say the fat cells are not just quiescent cells, they are very active and they pump out these pro-inflammatory mediators. And that, for example, can lead to insulin resistance. So that can induce diabetes. But the pro-inflammatory mediators are circulating in the body, and they can also affect the existing gingivitis or periodontitis and can worsen that chronic inflammation. So from obesity, you can get a enhanced progression of periodontal disease, for example, of periodontitis, or worsened gingivitis, which is a huge risk factor for periodontitis.
We understand the link between excess body weight and oral health, but which is actually interesting in the sense that we know that obesity is on the rise in the world. It's actually even more prevalent than famine, as you said earlier. So there is also now all sorts of treatments that are tried to cope with that issue. And one of the recent trends that is that are the headlines is the use of Ozempic to reduce the weight. So can you tell us a bit more about how does Ozempic work?
Yeah, so Ozempic is actually a synthetic or a pharmaceutical agent that mimics a natural hormone in the body. And the natural hormone is GLP-1 that actually is binding to a receptor. And when the receptor is activated by this natural hormone, it will give the person a feeling of that he has enough, he ate enough, so that he is feeling not hungry anymore. So that's one aspect. Secondly, it is when the receptor is triggered, it takes care of reduces the pro-inflammatory mediator release of cells. So it works also anti-inflammatory. And in that way, it also has an effect on the immune system. And because we think that people eat less because of that feeling of I'm not hungry anymore, they also lose weight. And the Ozempic is popular suddenly, although it is a medication originally for diabetes, because it will increase the insulin production. It may help people to lose weight. And maybe the loss of weight also helps to reduce inflammatory status. We don't know exactly, but it all comes together. So the analog of the natural hormone binding to the receptor, GLP-1 RA, receptor antagonist, that's the pharmaceutical analog, that mimics a natural hormone and has not only an effect on the insulin, but also on the hunger feeling, on body weight, on immune system. So suddenly it is very interesting because for people to lose weight, but also it has an anti-inflammatory component to it. And that might be interesting even in the field of periodontitis or periodontology for reducing inflammation in general and maybe reducing the inflammation of periodontal lesions.
I was going to ask about that because I know there's some preliminary research and some in vitro and animal studies on the effect of Ozempic on periodontal health. Are there some interesting trends or findings that could be interesting for the future?
Yeah. So first of all, there's in vitro work. People have tested the analog, the drug in periodontal ligament cells, and when they are stimulated with a inflammatory component like LPS or endotoxins, they pump out less amount of inflammatory mediators when there is also Ozempic present, or the analog. Ozempic is more the generic brand, with which we should say the GLP-1 RA.
It's difficult to remember. Yeah, Ozempic is easier.
Yeah, but there are many names, semaglutide and others.
Ozempic will be happy.
And so, and also there are preclinical studies in animals with an experimental periodontitis model, where they show that the animals having the drug are showing less alveolar bone loss and less pocketing and less inflammation in the experimental periodontitis model. And also people have shown there are some very few clinical studies, but one clinical study where people with diabetes and periodontitis were treated for the periodontitis, got periodontal treatment. When they were on the Ozempic, their treatment was much more successful and their inflammatory status went down much better than when not on having the Ozempic.
Mm-hmm.
So it's a drug. I call it a positive side effect. We as periodontists should not prescribe it, but when patients are having it or getting it prescribed from their physician, and if they have periodontitis, the periodontitis treatment will really add up in becoming more healthy, the patient.
Yeah, we talked about this before today, of course, and I quite liked one angle you mentioned is once a patient starts the treatment with Ozempic, that's sort of a milestone in his life or her life, where you start taking care, actually proper care of your health, of your overall health, which may then also be a nice reminder or a good starting point for a professional in the oral care field to remind them.
Yeah.
Don't forget, if you now start taking care of your systemic health, why not also start to boost that by also starting to take care of your oral health? Because it's as we said now several times, it's linked.
Yeah.
So it could. Yeah, I quite like that approach you mentioned.
I think that is good, and also the use of or the better oral health care the patients have, brushing and interdental care, is a moment that taking the Ozempic, having the treatment for periodontitis, becoming more healthy, losing weight, and then also improving your own oral health by better oral health care at home, daily oral health care.
That would also support the interdisciplinary care of the patient.
Yeah.
Because as you said, Ozempic is not prescribed and should not be prescribed by dentists. So it should also be in the speech of the physician to take care of the gums, basically.
Yeah, it would be good if physicians realize that the drug that they prescribe would have beneficial effects also for gum disease. Mm-hmm. Definitely. But we should be careful. It is preliminary work, and we have not a lot of data.
No.
But it is a interesting drug with, you can say, positive side effects and doesn't harm the periodontium.
Yeah.
Even though it's a hypothesis, you still said that there is this anti-inflammatory side effects of Ozempic or GLP-1 that could be interesting, which leads us to the common denominator of all these chronic diseases and periodontal diseases, which is inflammation. And with inflammation, there are also the biomarkers of inflammation that we could also now screen. But before we go into the biomarkers and which are the most well-established or well-known, inflammation is also linked to the concept of immunity, as you said, and this immunity fitness particularly. So maybe let's start by define what you mean by immune fitness.
Yeah, it's a term that I have seen in the literature, the general immunology literature. And it is a term that really helps to understand that your immune system or your host response, the way you want to call it, can have a certain level of fitness. People know about physical fitness; they go to the gym, etc. But your immune system can also be trained and boosted, and be performing well. And that I call immune fitness. There are many aspects that can affect immune fitness. Let's take a few examples. If you have a poor diet, for example, very little fruit, so you have very low levels of vitamin C, then your immune fitness will be lower. If you are short of vitamin D, for example, your immune fitness might be lower. And whenever you have in your system inflammation, like from obesity, your immune fitness may be lower. So there are many aspects in the lifestyle part, but also unfortunately in the genetic part that determine a certain level of immune fitness per person. You can do something about it. You can you can boost your immune fitness again by having a good diet, by losing weight, by stop smoking. Those are all aspects that help to boost your immune fitness. And so it's a term that I have been using for also in my patient care. And they say, okay, so that is something I can do myself. And your immune, say there are 3 clusters within the total multi-causality of periodontitis: the genetics, the lifestyles, and having unfortunately, a systemic disease or condition. Those 3 determine the level of your immune fitness. Controlling your systemic disease is one aspect, like controlling diabetes. But in the lifestyle part, people can stop smoking, lose weight, so take care of a good diet, and there are many more aspects, having less stress, etc. That all of it can boost the immune fitness. So it's a term that that makes it understandable and is useful. But I didn't invent it. I picked it from the immunologist.
Yeah. We often talk about. Also, internally in our company and in our content and articles, we often talk about the concept of immune fitness. But what is the role of oral care professionals in trying to work on the immune fitness? You mentioned a few clusters, but of course, a hygienist or a periodontist or a general dentist, they're not per se lifestyle experts. They would, of course, only have a limited time with the patient. And so, what would be your recommendation on how to make the most of the possibility of they are in frequent contact with the patient, how to leverage that time to work on those clusters?
I understand what I wrote somewhere sometime in one of my papers is that the dentist, the periodontist, the hygienist is not only somebody who is an oral care giver and performing all the time a procedure, but also is part of you can say a team of coaches that helps each person in their lifestyle.
Yeah.
So we should take up a piece in lifestyle coaching, and that Martijn, is not so difficult because we see problems in the mouth. So we can say that one of the things you can do is stop smoking. And in the dental field, the stop smoking has been really worked out, and there are stop smoking techniques and also referral addresses for it. So that's one thing. And we can talk about their general health, how it affects their oral health, and we can recommend to seek help, for example, for overweight.
Yeah.
So many things are not so easy, but we should do it.
Yeah.
So
there's actually a big role for oral care professionals to. Yeah.
And that kind of fits also. You mentioned in the very beginning of our in this discussion the holistic care. The dental professionals are taking care of the patient and not only of the organ, the mouth.
Mm-hmm.
We should take care of the patient. And that means there's more behind the mouth itself. It's the whole patient. And the condition of the whole patient affects the oral cavity.
Yeah.
So if we want to get good results of our therapy in the fight of oral diseases, we should think about the other factors that affect the oral health.
So we have now a better understanding of what immune fitness is. Can you maybe detail a bit more about the mechanism on inflammation with its biomarkers, their role, the most well-established ones, so that we can understand better the cascade of inflammation?
That's a very, very difficult question. Biomarkers are, in fact, markers of inflammation, and that have been used to, you could say, characterize the inflammation, but it doesn't mean per se that they are also playing, say, the pivotal role in the inflammation. It might be a byproduct. So we have to be careful. Biomarkers is just a marker and not per se the true molecule that is part of the pathophysiology pathway in certain ways. Most of the time it is, but we have to be careful. But anyhow, just a way to recognize inflammation, we like to use biomarkers. But today still the typical biomarkers as like interleukins and prostaglandins are important in the whole inflammatory process and can be used as markers of ongoing inflammation. There is for years already the interest to say, can we screen for periodontitis using these particular inflammatory markers or biomarkers? So that has been done, but always I doubt if it is some useful tool for the dental professionals, because we have the patient in the chair and we can do quickly an oral examination and see if there's inflammation of the gums, bleeding gums, etc. So the screening for periodontitis is more something that could be useful in a physician's office or in a hospital where people are treated for other diseases, and where the physician is very knowledgeable and understands that also processes in the mouth, like periodontitis, can contribute to the difficulty of controlling the disease, or that it contributes to disease. So physicians may be interested in having a simple screening tool for periodontitis. And there, I think, if companies like yourself are interested in developing screening tools, the biomarkers, the immune markers might be the first choice.
If you say it's not really for dentists but more for physicians, then you mean not based on the gingival crevicular fluid, for example, rather on blood or on salivary based tests?
I think it is rather difficult to take a crevicular fluid, gingival crevicular fluid, and that process of taking gingival crevicular fluid, it's a difficult
GCF. Let's go.
Is something that you can easily use your probe and see the inflammation or bleeding on probing. That is my, I can say, personal view. I know there are people who say, okay, we have a chair-side diagnostic test for periodontitis, but we should be able to to at least screen quickly and then do an extensive diagnostic procedure. So the screening is more, I think, for outside of the dental office. That's my personal view. And then inside the dental office, it would be nice to screen for example, unknown diabetes.
Yeah.
So the dental office can say focus more on, can we help the holistic approach to the patient? Can we screen for diabetes or cardiovascular disease risk? And so that is a different thing for the dental office.
You have quite some research on that as well.
Yeah, because we found that quite some people in the periodontal office, patients, have a higher risk for cardiovascular disease event in the next 10 years than people without periodontitis. And again, we talked about it before, the diabetes. The prevalence of diabetes is much higher, and also unknown diabetes in the periodontitis. Yeah. In the periodontal office, people with periodontitis. But the biomarkers is very interesting, and I'm involved in that research. If we can see if there's for physicians or even for home use a set of salivary biomarkers that we can use for screening of periodontitis, diabetes, cardiovascular disease, if it's present in the mouth and and we have to find out, we are still in the process, if you can find unique protein signatures or other metabolomic signatures or microbiological signatures that correspond to to underlying diseases.
I remember you also talking about fingerprint, the salivary fingerprint.
Yeah, so that would be, because I think having one marker is never going to help us. It must be a set. And today in the omics time, using proteomics and multiple proteins, hopefully we can find a set, a fingerprint of proteins that could discriminate patients with and without diabetes or unknown diabetes or their high levels of glucose. Having high levels of glucose, we can measure glucose in saliva. So there are things to do that we can measure in the oral cavity. Actually, we are in a very nice position as dental professionals because the mouth is easily accessible as a gateway to the rest of the body without taking blood. Although we haven't found the right markers yet.
Yeah. But salivary then. Right?
Yeah, so it could be, I can say oral fluids. Let's make it oral fluids. Yeah. So that's a mix of saliva plus gingival carflicker fluid. If you ask people to rinse, for example, have oral rinses.
I would like to talk now about a trip you made in the US. You said that you spent a decade almost in the US earlier in your career, but actually beginning of this year, you also spent a mini sabbatical at Harvard Dental School of Medicine.
Yeah.
Why? Why did you go there?
Right.
What did you do there?
Yeah, so it was a good opportunity after I don't have much, not so many responsibilities anymore in the department except for the research and the PhD students. That a nice opportunity to travel around, and I was invited by the dean, William Ginobili from Harvard School of Dental Medicine, to spend a short period of time there. So it was very nice, and I thank Sunstar for sponsoring me as well to spend some time there. And so I had what we call indeed mini sabbatical. It was very nice time to spend some time in the Department of Oral Medicine, Infection and Immunity with Professor Ferris, and also the Department of Regenerative Medicine of Dr. Ginobili, to meet people in their labs and to exchange ideas about the research that was ongoing. I was invited to write some review paper, so I thought this is a nice sabbatical. It's a nice moment to find some rest and secluded moments to write on these reviews. So that's what I did.
I think one of the papers that we are very interested in is because it's a topic you do not really hear that often. I, for example, had never heard of the topic before we prepared for this podcast, which is the salutogenesis.
Yeah.
Salutogenesis is a term used in the medical field, but now you also hear it in the context of periodontology. And as we do not know anything about it, we were curious to hear your thoughts, because that's one of the papers you're going to write or are writing following your sabbatical. Yes. Yeah.
So that was one of the main things to write about salutogenesis, and that's a term also for me was rather new, but it actually is the opposite of pathogenesis. So basically what you look for in biological terminology is to see which factors are inherent or characteristic of a person that makes the person resistant to periodontitis. So why is the person not developing any periodontal disease? What salutogenic factors are there inherent to that person? And by studying that, I followed a little bit my multi-causality model for periodontitis. I said, okay, now I have 5 clusters of causal factors for periodontitis. Let's see within those 5 clusters which factors can be found that are really protective for periodontitis.
Yeah.
So I looked for genetic factors, and there indeed is literature that shows that certain genetic variants are associated with not developing periodontitis.
if I paraphrase what you are saying, salutogenesis would be the factors that create health, and pathogenesis would be the factors that create disease. Is that?
It is not create, but are the factors that some person has that makes him more resistant to the disease.
So you're approaching a person from a state of health rather than, because we're always used to talk about disease. And always when we talk about patients, we talk about disease, but this focuses on the health of the patient and try to understand why that person is still healthy despite some factors that in other people would cause disease.
And actually what I learned, and because I wrote it together with Magda Veres and Will Ginobili and Hatis Hasturk from Foresight Dental Center also in Boston. By focusing on why somebody does not develop the disease actually helps us to even more focus on those factors when they have the disease, and to understand if you can change certain lifestyle factors that may help to become in a higher state of immune fitness. Coming back to it again.
Yeah.
But so we have genetic factors that appear to be in the literature, helping a person to be resistant to periodontitis development. But a big chunk is the lifestyle factors. People who are not obese, people who are having a very good diet, a balanced diet, are low, you can say, on a Western diet and high on Mediterranean diet, intake of olive oil, all that, not smoking, and particularly looking at the diet of people who become 90, 100 years old, then without any diseases. So there we learned from what lifestyle factors are that help to maintain a normal, balanced immune system that protects against the development of a destructive inflammation. Periodontitis is destructive inflammation. And also that on itself helps also to be resistant of developing other diseases. So those people who are lucky not developing any form of diabetes, other inflammatory diseases, also will not have that extra factor to stimulate or to push the progression of gingivitis towards periodontitis. Mm-hmm. So that is a little bit what we did, and also we looked at aspects of the microbiota in the oral cavity, because there are also certain, what you can say, eubiotic components of the oral microbiota.
We had a conversation in the last season of Let's Talk Oral Health on primary but also primordial prevention.
Yes.
And there seems to be a lot of overlap because, as you said, there's the cluster of lifestyle factors that are part of this salutogenesis concept. But I quite like the fact that, primordial and primary prevention focuses on those factors mainly, but the concept of salutogenesis goes beyond that, because it's not just that cluster, but you also have oral hygiene and you also have genetics. It's a whole set of factors that keep a patient healthy.
Yeah.
And that emphasizes sort of the holistic approach that we have. We're not just cleaning mouths, but if you take into consideration the lifestyle and the genetic background and the development the person goes through life, you have a much better picture of why this person develops disease or stays healthy.
Yeah. Some people are more lucky having the right genes, for example. And also, you can say the resources to consider their own health and be in charge of their own health. That helps.
Yeah,
that helps. So in a regular dental practice, many people do not have yet periodontitis, but it could be they develop in some time. They may develop periodontitis. Yeah. But if you are aware as a dental professional that there are factors that make the patient more resistant, so then you can always say, I see some gingivitis that can derail at some point to periodontitis. But if you can maintain a certain lifestyle and stay healthy and realize that you should not smoke, but also think about if you develop any disease that you take care of it, then all in all, your you can say your immune fitness and your total strength is increased, and you may also protect yourself against the development of periodontitis.
Little side quest maybe, that's just a thought that now pops in my head, but do you think there's also that this concept of salutogenesis is maybe also what underlies these what we call blue zones in the world? You know, you have these little zones in the world where, without a really clear explanation, people get a lot older than the area directly around it.
Yeah. So but that could be genetic, because people in certain areas may have marriages.
Right.
So that's a possibility.
Yeah.
But also the type of diet they have and their culture.
Exactly.
So in the Salutogenesis paper, it became a massive paper. We also talk about cultural differences.
Right. Yeah.
And the concept of salutogenesis, maybe that's also actually came from survivors of Holocaust experiences, where it was seen that certain survivors, although have suffered from major life-threatening conditions, could cope with that, could deal with that, and could stay healthy, while other people may suffer from post-traumatic stress, etc. And that is where the concept initially was studied and brought forward. Old age in a rather healthy situation, even though they had these Holocaust experiences. And so it's not only, and that is also for our perio field interesting, the lifestyle in terms of diet and the genetics, but it's also mind over matter. It's that how you can cope and deal with certain life stressors, I mean. So we have to keep that in mind. That was
interesting.
Another aspect. We haven't mentioned much stress, but that is another aspect that could reduce your immune fitness.
It seems to be a big psychological aspect as well. Yeah.
Body, mouth, and mind, actually.
Yeah.
To take into account.
Yeah. But I think a very important take-home message of our discussion today is that we have to realize the diseases, the chronic diseases. We are working with periodontitis, others work cardiovascular disease, with diabetes. These are multi-causal diseases. So it's never only stress or only bacteria or only genetics. It's always a combination of things that makes somebody eventually susceptible for the disease.
Yeah.
But before we wrap up, you said that the paper on salutogenesis is becoming massive. But apparently your sabbatical to Harvard School of Dental Medicine was very productive, because you have another paper where you talk about the past, the present, and the future of periodontology. And it would be nice, I think, before we wrap up, to see what you think of the evolution of the periodontal medicine. Looking ahead, what do you see in the future?
Is it massive as well, the paper?
No. It's going to be a very short paper.
Okay.
It's more what we call perspective. But the future, obviously it's very difficult to foresee what happens in the near future, and we are always kind of using the current times as to extrapolate from the current times to the future, and but the further future is very difficult. But I foresee enormous use of the artificial intelligence. That is what I think happens. I'm very fascinated by the possibilities. Artificial intelligence particularly is designed to predict. So if we talk about a chairside test at some point, we don't need the biological chairside test anymore. There will be other, we can say, tools where there is absolutely not invasive and not using the mouth itself, but rather using questionnaires or medical histories, dental histories, to predict if somebody might develop periodontitis. And I'm helping a student on an AI model using dental records to predict if somebody may develop periodontitis. And recently a nice or large paper came out that uses medical records to predict more than 1,000 diseases in the next 4 years, 5 years, 10 years. So that might be the direction that we may also go into if you think about periodontal medicine and the relationship between the mouth and the overall health. So dental professionals at some point, or maybe not even in the dental office, but you can give at a certain moment, you can give certain questionnaires, and with algorithms behind it, can say you have a higher risk. Everything is probability. Yeah? So you may have a higher risk or higher probability to develop diabetes, to develop cardiovascular disease. And the dental office is quite a nice place because we talked about it. We see patients every year or twice a year. Yeah. So you can monitor and redo those questions. Patients go more often to a medical office if there's a true problem. Yeah. So if you can use future artificial intelligence tools to predict, that would be very nice. Yeah. So that would be some sort of a utopia for me. Yeah. And I would love that the future is that dental offices or periodontal offices, let's keep it as simple, is that they combine all the records and that you get a good data set to develop AI algorithms for predicting diseases and the progression of the disease, periodontitis. And also predict who needs more interdental brushes and more attention for that.
That would be very useful.
Yeah. Interesting times lie ahead.
Yeah. And that's your views on the future of periodontal medicine. You mentioned the PhD student already. What's in it for you in the near future? You said already, being an emeritus professor, stepping down a little bit from teaching, and of course treating patients as well. You're focusing now on your PhD students. Is there some nice projects going on? I suppose so. What is ahead of you in the coming years? Well, wrapping up those research projects.
It will come naturally, I think. But I'm very interested in how periodontal medicine and the whole field of periodontology develops itself, and I would like to stay active in it. Yeah. And I will collaborate and help young colleagues to do their research. That's my goal in life, and also my pleasure in life.
I think we have come to an end of our conversation. So thank you very much, Bruno, for sharing all this deep, insightful information with us and with our audience. It's really been an honor to have you with us. Yes. Thank you very much.
Well, thank you, Rachel and Martijn. Thank you very much. And it was my pleasure as well, and my honor to be here. And I would like to congratulate you and your company also with your mission and vision on oral health and general health. How you work on that topic is very nice. Congratulations.
Thank you. We'll continue in that direction then.
Good. Excellent.
Thank you all very much for tuning in. Well, I hope that you enjoyed the conversation and that you took some advice for your daily practice. Martijn and I will be happy to see you again at our next episode with a new conversation and a new guest. See you soon.